Okay. A very good afternoon. I thank the organizers for giving me this opportunity. So I'll be taking on the WHO 2021 classification on the CNS tumors. So the goals of this presentation will be the first, the key innovations, then what are the new types, what are the obsolete types, and what are the ones that were updated. So when you see the WHO CNS classification timeline, CNS is pertaining to the one tumors relating to brain and spinal cord as opposed to those in the peripheral nerves. So in 1979, they brought out the first edition, and then in 1993 and 2000, they brought out the second and third edition. So most of this were mainly on the histological basis. Then they expanded the histological types with IHCs in 2007 and further revised it in on 2016. Now, they have fully integrated the molecular and histological classification in the 2021 WHO classification. So it's a big book. So there is one good article by David and Louis who had summarized this changes in the WHO 2021 classifications. And some of the key innovations in the new classification is, first, it is an integrated layered diagnosis. So there is a each section wise, the diagnosis is split into each section wise, where together all the sections combined will give a proper diagnosis. Next, it will depend on the tumor types, and there is also intra-type grading. Then, adult and pediatric glioma, they have split into two separate entities now. Then, there are some new tumor entities, and there are some other terminologies like NOS and NES that is not otherwise specified, where the essential diagnostic data is not available to characterize the disease, and NES that when even though the whole testing is done, we couldn't, the tumor that we have does not align to the different defined categories. Then, other than that, there is a essential and desirable diagnostic criteria. Essential is the ones that is must have necessary features for the diagnosis, and desirable is supportive but not mandatory in the current features. So initially, when the diagnosis of brain tumors was easy, like we are in early before 2000s, it is like having a black and white TV. Now it's with all the colorful markers and all. Now it's become like a 4K TV. So the layered diagnosis is, first is what is the tumor type. Next is what is the histological features that is seen. Then WHO grade, that is earlier it was now it is made into the Arabic numerals, that is to prevent any typos and interpretation differences while reading it. Then there is molecular features and other additional notes like site and methylation. So this is the table from that article. So in places where you have the complete available details, we can assign it accurately, but otherwise we can assign it as NOS. That is not otherwise specified. If we have full molecular markers, then we can correctly subtype it and then put a diagnosis integrating that. So this is the grading also I have mentioned. It is in the Arabic numerals now, up as opposed to Roman earlier. And they are classified into various grades like 1, 2, 3, 4, 4 being the highest one. The entire classification, if you see, it's a long list. And they are also given the genes and molecular profiles also accordingly. Major headings will include gliomas, glioneural and neural tumors, ependymomas, embryonal tumors, pineal tumors, cranial and paraspinal tumors, meningiomas, cellular tumors, metastasis, and hematolymphoid tumors. Coming to adult type gliomas, it can be astrocytoma, oligodendroglioma, or glioblastoma. And one thing is, as opposed to the positive and negative IDH earlier, now it is IDH mutant or IDH wild type. So astrocytoma, there is a IDH mutant, and grades can be 2 to 4. So there is a WHO grade 4 astrocytoma IDH mutant currently in the classification system. In oligodendroglioma, there is IDH mutant with 1p19q co-deletion, and it is grade 2 or grade 3. Glioblastoma is grade 4 with IDH wild type or TERT and EGFR positive or chromosome 7 positive and 10 deletion. So there was a question earlier regarding 1p19q. So in case 1p19q is not there, then also ATRX with ATRX and IDH mutation, we can sort of like classify into whether it is going into astrocytoma or oligodendroglioma. But 1p19q deletion is co-deletion is preferable when it is oligodendroglioma. Other than that, if IDH it is wild type, and with this following features, it will go into glioblastoma. Pediatric type diffuse gliomas are two types. It is low grade and high grade. And low grade will have diffuse astrocytoma, angiocentric glioma, plenty, and diffuse low grade glioma. And then high grade will be diffuse midline glioma, H3K27 altered, H3G34 mutant, and there is H3 wild type, IDH wild type, and infant type hemispheric glioma. Ependymoma classification is a device subdivided into supratentorial, posterior fossa, and spinal. And the supratentorial SFTA fusion is now included. And according to the various subtypes, the prognosis and fusion and other characteristics are different. And location-wise also, they are different locations altogether. Medulloblastoma now it's there is four subtypes, four subgroups. That is WNT, SSH, and the ones that doesn't confer to both of the above. That is group 3 and group 4. So best prognosis is WNT and SSH is TPH53 dependent, and group 3 and group 4 will be variable to poor prognosis. So this is just a diagram representing the various subgroups with the prognosis and the mutations that is present, and also the age group. And SSH is again classified into four subtypes, and that is again total coming into eight subtypes. Meningiomas is assigned into WHO grade 1 to 3, and there are some molecular markers for grading. So there is TERT mutation, TERT promoter mutation, and CDKN2A and B homogeneous deletion. So irrespective of the histological subtype, if they are positive, then it is upstaged. So grade 2 uh, with TERT promoter and CDKN2AB will be staged as grade 3, apart from the usual histological subtypes that is already there in the previous classification. So the new tumor entities, there is 22 new tumor types included, and it is based on the molecular profiling data that is available, and also the according why molecular profiling is included as the prognosis also is different when you take into account the molecular profiling. So accordingly, there are newer classifications and new subtypes are there. Astroblastoma is one of the example. Then one thing that we are nowadays seeing more is intracranial mesenchymal tumor, and this is we are seeing more of these patients also now, according to the new after the new WHO classifications. Then there is cellular tumors. Cellular tumors will be pituitary and craniopharyngioma, and craniopharyngioma is also subdivided into two different types. Obsolete tumor types are the wording of anaplastic is no longer used. That is grade 3 now. Then gliomatosis cerebri is now considered a growth pattern and not separate subtype. Then primitive neuroectodermal tumor is reclassified into a specific embryonal tumors. Earlier, there was a diagnosis like oligoastrocytoma, and that is now discouraged, and it is advised to use the molecular criteria to define it into one of the astrocytoma or oligodendroglioma. The updated tumor type is glioblastoma is reserved only for IDH wild type, and if it is mutant, it is astrocytoma grade 4. Medulloblastoma and ependymomas are subdivided and based on the molecular groupings, and uh, because even though the diagnosis is medulloblastoma, the different subtypes have wildly varying prognosis. So that's why they have subclassified into various other groups. So cellular classification, cellular tumors, previously the adamantinomatous craniopharyngioma and papillary craniopharyngioma, that is divided and made it into the main section itself nowadays. Then pituitary adenoma or PNET is the another terminology that is added, and it is mainly due to the compliance issues of the insurance in US. So, what are the clinical relevance? It guides the therapy and prognosis better. The patients will also be informed about the prognosis, more better accurate prognosis. And according to the molecular classifications, there are targeted therapies now available. IDH mutation shows a better outcome, and sometimes we can see for de-escalation or alternate regimens. H3K27 is poor prognosis and requires aggressive approach, and this also helps in the better stratification of the trials in the future. So, in conclusion, the modern classification is more of a histology and molecular, and there is a different sub. The gliomas are divided into adult and pediatric gliomas, and for accurate diagnosis, molecular diagnosis is essential. So, this is my institution, divided into three campuses. Thank you, and I'll be happy to take any questions.
Thank you, sir, for your such a nice presentation. I hope that we all have got an in-depth idea about the classification of the CNS malignancies. Now, regarding the